Today we'll be talking about treatment-resistant depression. So in this class, we'll be going through some things. That will be first, why is it important? Then we'll be talking about the classification systems and the definition. Then we'll talk about the risk factors. Then we'll go to treatment. The references that I've used for this include articles which have come in the World Psychiatry Journal as well as the IPS guidelines as well as the original classification staging systems. And for treatment, I've also referred to Ortsley's. So let us start with why is it important? Very important question. Why? So first of all, treatment-resistant depression is important because it's a public health concern because more than 100 million people with depression meet this criteria somewhere, any one of the definitions. And there is higher cost because they involve a lot more in the healthcare systems. There is increased suicidality, and there is definitely increase in comorbidities. It can be medical as well as other psychiatric comorbidities. And hence, it is important and it is imperative that we have a proper treatment. So, what is the problem now? So the classification itself is a problem with treatment-resistant depression. We have many classificatory systems, but nobody seems to agree on a certain consensus. The definition, for example, in some classificatory systems, we have treatment-resistant depression with even one resistance. We can call it TRD. In some classificatory systems, you need at least two. So all these things, so that's what I'm trying to say. There's no consensus. So that is something you need to know. So we'll be talking about five classificatory systems here. So the first one is definitely the Thane and Rush model. This is, sorry, the Thase and Rush model. This is the one of the first ones. And according to this, you only need at least one for resistance. So it is easy to remember. So there is stage 0, 1, 2, 3, 4, 5. 0 means inadequate trial. 1 means at least one adequate trial of one class. 2 means more than two adequate trials of two classes. Okay. Now 3 is stage 2 plus TCA, tricyclic antidepressants. Stage 4 will be stage 3 plus MAO inhibitors. Very good. MAO inhibitors. And stage 5 will be stage 4 plus ECT. So how I remember is stage 0, 1, 2 you'll be able to remember and the rest you can remember by TME. TME. Okay. Next what we learn about is the other classification system is the Massachusetts General Hospital classificatory system or Massachusetts General Hospital staging. So this is more of a scoring system than a staging. So you have to score. So there is stage 1, 2, 3 and the scoring is 1.53. What do you mean by this? Stage 1 if there is a failure of an adequate trial of any class of any the trial should be at least 6 weeks, okay? More than 6 weeks trial. So there is one more thing, there is no duration of the trial in Thase and Rush. But in here they're telling at least 6 weeks trial of any one class. This thing is required. If any one trial is there, we can add one score of 1. Next, zero point 0.5 will be for any augmentation or optimization strategies. For everything, you can give zero point 0.5 and 3 is for ECT. So you have to score. Suppose the patient has two inadequate trials with one optimization and one ECT. The score will be 1 plus 1, 2 plus zero point 0.5, 2.5 plus 3, 5.5. And if you compare with one patient with only one adequate trial failure, it will be just one. So this first person has more treatment resistant than second one. So that is the whole thing about the Massachusetts General Hospital. You can compare. And the 6 week they're giving. Now the third one is very important is this thing. Third one is the European staging model. So there's a European group for study of treatment-resistant depression. They have a staging model, European staging model. So according to that, again, so there is two things. One is non-responder, then is treatment-resistant depression, and there's something called chronic resistant depression. Okay, so non-responder here is just one adequate trial failure. Is one adequate trial of very important antidepressant or ECT. If you see in the previous both definitions, previous both classification, ECT came to the last. But here, even ECT first failure itself, you can call it non-responder. You can't call it TRD yet. Very important. Now, the European system tells you can only call it TRD if there is at least more than two adequate failures. And according to that, they have a further divisions of TRD from five substages. One to five substages are there depending on the number of weeks. It starts from 12 to 16, 18 to 20, like that. There are weeks up to 52, up to 1 year. So, up to 1 year failures will be under TRD. Very important. And they can divide into five stages based on the number of weeks. What is CRD? Chronic resistant depression is anything more than 1 year. So it is any stage of TRD which is persisting more than 1 year. You can call it CRD. The next classifications are very important. The one which all of us study or our books is Maudsley classification. Maudsley is very easy to learn. You can read it. So there are five stages. Five. Again, this is a scoring thing. So first is the duration, symptoms, symptom severity at baseline, symptom severity at baseline. Then you have the what do you say, treatment failures. Then you have augmentation, ECT. Okay. So treatment duration will be acute, subacute, and chronic. And very important, the durations are not like you think. Acute is less than 12 months, 12 to 24 months, more than 20 months. Symptom severity, they classify it as subsyndromal, syndromal. And syndromal is further classified into mild, moderate, severe. Treatment failures, again, it is classified into five subcategories. Unit is one, two, three, four, five. Failure of one to two medicines, three to four meds, five to six meds, seven to 10 meds, more than 10 meds. Augmentation, you can write it as augmentation done or augmentation not done. ECT also, ECT done, ECT not done. Failure. The scoring is simple. How you do is it's all 0, 1. So for this will be 1, 2, 3. 1, 2, 3, 4. Oh wait, here I made a mistake. So this is severe without psychotic and severe with psychotic. You have to tell that. I'm sorry I missed that. So severe without psychotic, severe with B 5. 1, 2, 3, 4, 5. 1, 0, 1, 0. Total the maximum is 15. And based on 15, you can call it as mild, moderate, severe TRD. So mild will be 3 to 5. Sorry, mild would be sorry. Mild will be 3 to 6, 7 to 10, and 11 to 15 total score. Okay. There's one more classification system that is written in the World Psychiatry article. That is DMRD classification. DMRD is Dutch measure for quantification of treatment-resistant depression model. So DMRD is the most comprehensive one. You don't need too much detail, but just remember it's the most comprehensive one. Because why? It includes many other things. So, for example, it includes childhood uh, sorry, it includes functional impairment, it includes anxiety, it includes personality, it includes psychosocial stressors, it also includes psychotherapy failures. Okay, so these things are not included in the other models. So, DMRT. So, as you know, we have classified 1, 2, 3, 4, 5. So, we studied the Thase and Rush, we have reduced the MGHS, EGSRD, mod. We studied the Maudsley and we studied the DMRT. So, five classification. Now we'll talk about the risk factors. Who will have this? Very important question that we need to consider. So there are a lot of risk factors. So first you have the environmental or the social risk factors in my social. Then is the clinical risk factors. Then you have some neurobiological, neurobiological, neuroimaging, yeah, the genetic and the physiological. So the environment and social, it will be lower socioeconomic status, poor poor support of family, chronic stresses. Along with that, they also tell childhood abuse, uh, childhood abuse. Then they talk about anxiety, and they talk about sorry, anxiety we'll talk in the next session. Sorry. Then they talk about older age. And since depression is more common among females, so even TRD will be more common among females. We can't exactly tell females have more risk of TRD, but due to the proportion wise, we can say that there's more risk in females. Clinical thing definitely, as I told you, there'll be comorbidities. Comorbidities definitely like for anxiety, personality, substance use. This will increase. Okay, anxiety, personality, SUDs. Then certain depression subtypes like atypical depression, psychotic depression, very important. And the other is comorbidities, like medical comorbidities like hypothyroidism. You know. So this is little tough to remember, and if you can, it'll be good. Okay, the neurobiological shall be mainly sleep disturbances, early awakening. Neuroimaging, you can talk about right frontostriatal atrophy. Just learn this. And the function or a decreased glucose metabolism in prefrontal cortex and parietal. Genetic, you can learn just this one. Polymorphism of 5-HTT-LPR. 5-HTT-LPR. Okay. And physiological, you can remember one of them again. That will be increased activation of HPA axis. Okay. So next we'll talk about how to treat. So, so now we are going to talk about the treatment. How do you treat treatment resistant depression? So the first thing we will talk about will be the evaluation. So when you talk about evaluation of such patients, you have to do certain things. One is you have to recheck your diagnosis. Because in many times in a haste, you might make a wrong diagnosis, you're giving the wrong treatment. It could be something altogether. But the most important thing that you have to rule out is bipolar illness. Because sometimes patient might not come, especially bipolar 2 or something, patients with hypomania and all, they might not present to you. They might be coming to you in a first stage of depression. And there are a lot of cases where the diagnosis has been made wrong and it was changed to bipolar later. So very important thing, there are some checklists that you can use or screeners you can use called the RMS. That is the Rapid Mood Screener. And there is something called a Hypomania Checklist. These two things you can use for what? Yes, to rule out bipolar. The next thing that you have to check out is to check out if there's any psychosocial stressors or anything that is complicating the issue. Because if that is not removed, how much you treat, you won't be able to see a lot of difference. The next important thing is you have to rule out any pseudo resistance. Because sometimes actually they might not have been taking medicines and then or the dose, everything was not right. You can't tell it was resistance. You have to rule out organic causes. So especially in old age and all, if there's a require, you feel there's something that could be organic, even imaging can be done if required. Okay. Next is you have to check off any medical comorbidities, medical or psychiatric comorbidities. Okay, very important. And also, you have to rule out any depressogenic medicines. That means medicines that can cause depression. If that is running behind, you need to remove it. So, what are the medicines that cause depression? Very good. Beta blockers, very common drug. Steroids, very common. And interferons, which we give for immunological conditions. Now, when you come to the treatment, basically there are three things I've referred. One is the IPS guidelines. In the depression guidelines itself, there is a flowchart for treatment resistant depression. Then there is the Maudsley guidelines. Before Maudsley, there's an article in the World Psychiatry Association in 2023. World Psychiatry Journal article. It's not the official guideline, but it is a good compilation and all. They have a table with different methods, which I'll mention. It's not a guideline from the World Psychiatry Association. Again, I'm telling. Then there is a Maudsley guideline. So we'll discuss all three, and it will give you a good picture. So let us start with the IPS guidelines. Okay. Yeah, it is a very simple. If it is TRD, okay, partial or no response, I will make the marker. Oh, it is small only. I'll make it a little more small. Okay. There are three options you can do. One is can augmentation. Three for augmentation. Next is combination. Next is ECT or RTMS. Yeah, the last one is others. Augmentation, they tell with what all? Very good. Lithium, thyroid, buspirone. Buspirone, not bupropion. Both of them are coming, so you'll get confused. This is buspirone. Okay. Combination is with TCA. We know TCA from where? Very good. We learned in the Thase and Rush model, we did TCA plus SSRI. Or MAOI plus, not sorry, not MAOI, sorry. Bupropion plus SSRI. This is buspirone. This buspirone, bupropion. Okay, so you don't forget. And ECT RTMS and the other strategies include what all? Very good. There's something called lamotrigine. There's something called metazapine. There's something called olanzapine. Do you know the olanzapine fluoxetine combination which you use? I'll discuss about it later in detail. Okay. And you give the treatment and then you can go for the continuation phase and the maintenance phase. This is the IPS guidelines. In short, only this much. Ashte. Ashte means only that much. Okay. Now we go to that World Psychiatry thing. That's a good thing also. World Psychiatry 2023 article. 1 minute. I just so that article has it. Just give me a minute. Yeah, it is written treatment resistant depression, the definition and all, and you can write it as McIntyre et al. Okay, if required, you don't need to, but yeah. So their strategy is another easy to learn that you can learn is. So one option is you can give antidepressants, then you can give ketamine or esketamine. Okay. Yeah, I just finished. So antidepressants either you can extend the trial. Again, it is not super effective because you can't say for how long you have to wait and all. So you can extend the trial, you can switch with another drug, or you can combine with another drug. These are the three options for antidepressants. Ketamine, esketamine, as you know, that is there. The next is second generation antipsychotics, and the main one is olanzapine. olanzapine, which we can combine with fluoxetine. The next one is somatic treatments, and that includes ECT, RTMS, and vagal nerve stimulations. If you see, ECT is a good, very good thing, but the problem is there's a lot of, not in India, but in other countries, there's a lot of difficulty, stigma. No? India also has, but we practice it more rapidly than outside countries. But RTMS, the vagal nerve stimulation, is much more easily acceptable. But the problem in India is it's not accessible everywhere and it's very costly. So for us, we prefer more of ECT. The other thing we can do is psychotherapy. Psychotherapy is one of the strategies. And this is something that is not mentioned in any of the other guidelines. So this is something that you can add for some brownie points. Novel agents. Okay, psychedelics. Yeah. So I think you might have thought. So this is psilocybin. There are studies trying psilocybin for depression, treatment and there is some improvement noted. The other thing over here is anti-inflammatory agents. So they consider depression as a chronic, what do you say, inflammatory process. So adding anti-inflammatory agents would help. And what are the things that they talk about is statins, COX-2 inhibitors. Okay. Now coming to the guidelines as per the Maudsley one, based on the Maudsley. Okay. So your first line, no, you have two strategies. You have your augmentation strategies, your switching strategies, you have others. Okay. Coming to augmentation, yeah, first line, second line. Okay. Second line. So first line you have lithium. You can go up to zero point 0.4 to zero point 0.8 milliequivalents. Next is olanzapine. Olanzapine plus fluoxetine combination, where olanzapine can be between 6.25 to 12.5 mg, and your fluoxetine can be 25 to 50 mg. This is called the OFC, olanzapine fluoxetine combination, OFC. This has a lot of data. Quetiapine is there. Quetiapine you can give up to 150 to 300 mg. Side effects are weight gain, dry mouth, constipation, and sedation. Aripiprazole you can give up to 2 to 20 mg. Problem is akathisia. All these are augmentation. These are all augmentation. So what is augmentation basically? You are adding a psychotropic agent that is not mainly for depression, but when it is added with an antidepressant, it enhances its actions by acting via different neurotransmitter systems. So this is augmentation, not switching or so it is augmentation. The words are very important. Okay, aripiprazole. The other, as we know, is bupropion. Bupropion. I put the same color here so you don't forget. Bupropion. Okay. Bupropion you can give up to 400 mg, and this evidence is from the STAR D trial, as you know. STAR D trial. And the last is Metas. Metas is a NASA drug, as you know. Meancerin is also Metas and Meancerin are both tetracyclic antidepressants, and under that, metazapine belongs to class 1 NASA. Okay, and metazapine you can give up to 30 to 45 mg, and Meancerin up to 30 mg you can give. So this is the first line. Coming to the second line, which we talk about here, ketamine or esketamine, and that is given 0.5 milligram. Ketamine is given 0.5 milligram per kVA IV over 45 minutes. Okay. Then there is lamotrigine. You can give 100 to 400 mg. Then you have buspirone. So here again, buspirone is first line, no second line. Buspirone you can give up to 60 mg. Risperidone can give up to 0.5 to 3 mg. and thyroxine. So thyroxine is second line here. And thyroxine, actually they did 25 microgram. Thyroxine you give 25 microgram in the first week and increase to 50 microgram over the second week. Now coming to the switching strategy. Switching means you change. So either you can give, so the switching will be SSRI to SSRI, not that beneficial. SSRI to SNRI, yes. And which is the best one? Venlafaxine. If you are in my college, we see like when you are not responding to SSRIs a long time, we are switching to SNRI, venlafaxine usually. Then yes, we can give SSRI to mirtazapine, very good combination. Bupropion also you have. Why bupropion? Bupropion is better in my way because it has very good. There is decreased sexual side effects. People have a lot of side effects, very impulsion more. So there is this. Then there is TCS. TCS are good. They have a steep dose response curve. That means for a small change of dose, the effect will be a lot. So that is TCS. Okay. Then there is nefazodone or trazodone, MAO inhibitors. Remember Chase Thomas, Thase and Rush, not Thomas and Chase, Thase and Rush. Thomas and Chase is, if I'm not wrong, this is the this thing, temperament. MAO inhibitors, norepinephrine reuptake inhibitors, and that you have like this atomoxetine and all. Then the other thing is switch to ECT, okay. And the other is other therapies, other somatic therapies. It could include surgeries like anterior cingulotomy and other treatments like RTMS, deep brain stimulation. One of the other approaches that we talk about is herbal supplements. Herbal supplements like St. John's wort, omega-3 fatty acids, and psychosocial interventions. You write this, the whole thing, I think will be more than enough for treatment resistant depression. Okay, thank you.